Our next speaker is Saleena Subaiya, MD. They are a clinical researcher and clinical assistant professor at the Substance Abuse Research Center at the New York State Psychiatric Institute at Columbia, and also the Irving Medical Center, which I'm assuming is a whole separate medical center. Dr. Subaiya will tell us more. And so this is public health and psychedelic medicine, access, equity, and the public good.
Good afternoon. Can you guys hear me? Okay. No. Yes. And I have a stool. How about now? Okay, yeah, I'm going to do my best. Thank you. So my name is Saleena Subaiya, and I'm an epidemiologist and a physician. I currently work as a clinical researcher at Columbia and Elias Dakwara's lab, evaluating ketamine for substance use disorders. I'm also leading a study of ayahuasca users that tracks a global group of participants before and after ceremonies over a 6-month time span. Interestingly, I have a background in public health and disaster medicine, which has given me the opportunity to work on everything from Hurricane Sandy and the Rockaways to cholera in Haiti. And I've also spent 2 years at the CDC, where I worked with the Epidemic Intelligence Service, and they're colloquially known as disease detectives, a group of scientists who are tasked to respond to outbreaks all over the world. So we've had the opportunity over the last few days to listen to many lectures on these medicines in a variety of contexts. I'd like for us now to take a step back and put all of what we have heard in relationship to a bigger picture. After all, we wouldn't be having these conversations, a surge in industry and research, and the globalization of these medicines if we weren't in fact facing a public health crisis of mental illness, of which these medicines are truly only a small sliver of the solution. So moving forward, I hope it's okay with all of you if we discuss public health during a mental health pandemic. Public health, which focuses on improving the health of communities through diagnosing disease, implementing new systems of care, and bridging inequalities, is something that requires all of our collective interdisciplinary action. I cannot stress this enough. No one else will do this unless we do. With as much unity as we can, with remembering the curiosity, the reasons that brought us into this room in the first place. After all, aren't we all in this together? My hope is to share some of my personal and professional experiences with you, and since you're a captive audience, some of my photography as well, and to leave you with 3 takeaway points. To better understand the scope of the mental health crisis we are facing in the wake of the COVID pandemic, the inequity and inequality that leads to worsened mental health outcomes, and how mental health illness creates greater inequity and inequality. And finally, the third point is to convince you that we have a responsibility to think and to act collectively, while also asking the question, what is best for the collective? This requires challenging systems that oppress and divide, and also understanding that if we simply focus on treatment within our respective niches, we will send people back out into a world that still needs to be healed. So it's hard to discuss the current state of mental illness without exploring the consequences of the ongoing COVID pandemic, during which I worked on the front lines in 3 New York City emergency departments. Ignorantly, I thought my prior experiences would protect me from the consequences of traumatic stress. Boy, was I horribly wrong. The sheer volume of seemingly purposeless suffering, the fear I saw in my colleagues' eyes. Many of them had to leave their families, their children, and slept in separate apartments for months. And the shattering reality of several painful suicides of our fellow colleagues, I found myself too broken. I figured others were probably experiencing similar struggles. So I developed and helped implement a hospital-wide survey for clinicians to put a finger on the pulse of mental illness among our staff. It was completed by several thousand physicians, and alarmingly, we found that 1 in 4 emergency department providers were suffering from severe symptoms of anxiety, depression, insomnia, and early PTSD. This was over 3 times what we would expect in this group, and this finding was echoed in other hospitals, both in New York City and abroad. In the US, we saw an additional 25 million adults with depression and anxiety since COVID. This is 25% higher than previous years. And in a survey conducted by the CDC, they found that during the peak of the pandemic last year, 40% of US adults reported struggling with mental illness and substance use. There was also a surge in overdose deaths, with more deaths in the US than in any other point in history. And while suicide rates appeared to fall in 2020, they exponentially increased in minority populations and young adults. While it is natural to assume that these numbers will drop once the pandemic ends, that's just not how mental illness works. Other studies from prior pandemics have taught us that there is lasting and persisting illness for years after an outbreak ends. So this is not something to be taken lightly. So in our hospital, we anticipated these higher rates, but I have to confess we didn't think they would be this high. In preparation, we actually gave clinicians their scores on these behavioral health screens. So if they scored highly, they would then get referred to therapy that was actually linked to their insurance. We thought this would be enough to help people access care. And do you know what happened? Nothing. The number of individuals that engaged with therapy did not change. We couldn't understand this. Here was a group of traumatized individuals in healthcare. Why wouldn't they want to engage with free care? We began having dialogue with individuals in government, thought leaders, researchers, and physicians, and we went back to our survey looking for answers. One main conclusion we found was we were relying too heavily on a treatment-focused solution. If we looked at this from a public health perspective, we could see the issues of stigma. People were afraid of how they would be viewed if they admitted they were struggling. Even in a group of physicians in a city as liberal as New York, people were still afraid of being judged. We also ran into the issue of mental health literacy. To have high mental health literacy is to be able to recognize symptoms of a mental health condition within yourself, and then secondly, to know that solutions exist, including professional help that is both available and effective. Or, for example, when and if these medicines are made legal and widely available. When we went back and reviewed our survey to see why clinicians did not engage in care, nearly 20% thought it would not benefit them. And finally, there was the pervasive fear of job loss and lack of career advancement, which speaks to the culture of mental health in the workplace. This study highlighted to me that until we provide solutions to these issues, it is not enough to offer a treatment-focused solution, like these medicines or therapy. We have to address upstream issues. I liken this to treating a patient with high cholesterol. A thorough physician would do more than just prescribe a statin. They would also address mitigating factors for having a poor LDL level. Things like looking at job stress, relationships, eating patterns, exercise. This story also highlights that just because you build it, it does not always mean people will come. Sadly, to date, over 1.5 years later, there were no changes made within our hospital to address these issues. I bring up this point not to criticize, but to highlight how challenging it is to change a system. Perhaps we can learn from communities like Burning Man, stepping outside of our usual modes of organization to allow principles of generosity, independence, radical creativity to restore us to a realm of possibility and exploration in the default world. Otherwise, we'll be left with the reality that even within a hospital network, even during a pandemic, even when mental health is making headline news, we could not make the necessary shifts to protect each other. And this was within a highly educated, wealthy cohort, which presents the question, what challenges are those from low socioeconomic groups facing? Rates of serious mental illness are double when adults live below the poverty line, and they are faced with significantly higher rates of stigma and lower mental health literacy. Social causation has repeatedly been associated with mental illness in low-income groups. That is, individuals who experience crime and violence, trauma, food and job insecurity, overcrowding and discrimination have higher rates of mental illness. I say this not to say that these conditions are deterministic, but rather that they have a profound impact on mental health. And to make matters worse, individuals suffering from a mental health condition have challenges maintaining their jobs and healthy relationships, all of which furthers isolation and worsens their symptoms. This theory, known as social drift, along with social causation, create a vicious cycle. Issues of racism and gender play a critical role in this, as women and people of color are more likely to be disenfranchised and are less likely to access care. We can see this as white individuals with private insurance are the most likely to access mental health treatment in the US. To make matters even worse, our research is also skewed, with the majority of large trials on these medicines reporting higher enrollment of white, non-Hispanic groups, and recruitment is primarily occurring in high-income countries. So how can we break the cycle? Can we just throw money at this? Believe it or not, several studies actually did that, and what they found was cash transfers and loans did not improve mental illness. And in some cases, it actually made it worse because of the stress and responsibility of increased financial responsibility. However, when interventions were put into place to improve mental health access and resources, it actually improved economic outcomes. This demonstrates how we can take a vicious cycle and turn it into one of promising and increasing returns. Improved mental health means people can go to work, they can engage with their communities, which can further improve their symptoms. This type of intervention is so critical if we are going to expect someone to leave their job and spend half a day in a medicine session or give up an hour each week for therapy. Without addressing the components of both social causation and social drift, it's like treating fish and putting them back into polluted water. So before moving on, I'd like to share one more story. If you've noticed, up until now, I've been sitting in this stool delivering this talk. And that's because 11 months ago, I was diagnosed with a severe case of long COVID. I have had and have profound fatigue. There are periods I couldn't read, I couldn't write, I couldn't speak, and I nearly fainted several times a day. Despite my profession, I actually encountered a fair bit of stigma. I had a colleague say to me, well, maybe you just have depression and anxiety. I had a physician tell me that there was no such thing as long COVID. There's just PTSD from surviving COVID. I even stigmatized myself, doubting the validity of my own symptoms. I felt quite alone at times. Despite this, I was actually able to amass an amazing team of care providers. I had my case presented at the CDC so they could evaluate for additional treatment options. My neurologist coordinated my care with so many different physicians, and they trialed me on over 8 medications. Unfortunately, I suffered a severe relapse that kept me confined to my apartment and most days my bed for several weeks. And at that point, I was lucky to take a leave of absence from work, to have the education and the finances to make massive lifestyle changes in diet, meditation, breathwork, you name it. and I sought treatment with ayahuasca. All of this had a profound effect on my health, and it's the reason I'm sitting here today. Had I only drank the tea without the needed break from work, the ongoing support of my neuropsychiatric team, and the ability to create stillness in my life, I'm positive the effects would not have been profound or as long-lasting. So as we move on to the third and the last point, I have a request. I implore each and every one of you who wants to enter the space of healing to consider adopting an expanded role, to work together outside of our niches to make the necessary changes to the system. It is not enough to just address treatment. We must also consider ourselves leaders, activists, care coordinators, and ultimately believers that pandemics, like the one we are facing with mental illness, requires public health solutions and all of our collective action. After everything I said, this may sound really daunting, but remember what we just went through with the COVID pandemic. We rapidly scaled up prevention, masks, social distancing, a vaccine developed at lightning speed, and it cost us a lot, the fabric of society as we know it. We took our kids out of school, we lost community gatherings, weddings, funerals. There's no reason to think that we can't do this now for the second pandemic we're facing, that of mental illness. So this next slide will review what we can do within our spheres of influence to begin to make shifts. The first is education. We are all responsible for this, for letting go of stigma, both in how we approach signs and symptoms of mental illness, and also in how we think of implementing modalities for treatment that are conventionally not seen as evidence-based. We also are all responsible for helping improve mental health literacy. We cannot rely on the government alone to share these messages. NGOs, startups, individuals, all of us, at the workplace, within your communities, we all need to help get this message out and be able to recognize signs of mental illness among our peers. The scope of the issue is too big to rely on someone else to take care of it. For those in the treatment space, coordination of care among primary care doctors, therapists, and psychiatrists has been shown to improve mental health outcomes, especially in groups with low socioeconomic status. Why can't we coordinate care with those who serve medicine as well, so everyone's on the same page? And with the surge of industry, it is impossible to not discuss commercial responsibility. Now more than ever, the private sector plays a large role in impacting public health. They exert powerful political pressure through lobbying, funding education, and funding research, which can skew towards commercial interests. As medications are FDA approved, organizations must consider how to address gaps in access and uninsured populations, and not just so they can bolster their marketability, in a way that is sustainable and sufficient to the task at hand. Additionally, private clinics should hold themselves to the most current evidence-based guidance to ensure proper dosing frequency, the most efficacious method of drug delivery, and proper patient selection. Researchers should conduct studies evaluating interventions that can be translated into policy changes, especially when it comes to vulnerable groups. There is no way the government will allocate funds for this unless there is data proving that these interventions impact mental health outcomes. Researchers should also consider stepping into the space of implementation. As we identify more and more treatments that are effective in phase 3 trials, we have to test them in real-world situations. This will help us understand what are the things necessary to maintain high treatment effects. Additionally, these types of studies can be useful at bridging inequalities. For example, by demonstrating how to successfully implement a psychedelic treatment program in a low-income minority neighborhood. And finally, we all must consider how we can implement upstream interventions. So we are preventing the occurrence of mental illness. in addition to considering treatment. One example that is simple is training behavioral health-minded leaders. That helps create a culture of mental health in the workplace, and that's actually been shown in high-risk occupations to mitigate mental illness. A more challenging issue is considering the detriments of capitalism in healthcare. I really have to ask, is this what we all want? If we are being honest, we all have different motivations for doing this type of work. And if we are truly to create a paradigm shift, we must explore what is driving us. While altruism is undoubtedly a very real motivator, we must be wary of bolstering our ego, furthering our career, chasing power, and financial gain at the cost and exploitation of vulnerable individuals. Because let's face it, without this, we are barreling down a seemingly irreversible path. Decades have taught us that the world will not become magically equitable for health. Economic decisions will not automatically protect the most vulnerable. Globalization will not suddenly create affordable treatments or medications for everyone that needs it. This is a plea to not further this trajectory. It is only with this awareness, with intentional and deliberate policy decisions, a rethinking of our research strategy, and deconstruction of motives behind commercial interests, that we will then begin to make this desperately needed difference. And the last thought I'll leave you with is this: none of us would be here without this beautiful planet, which endlessly nourishes us and supports us through all of our misgivings. We should be very respectful of our relationship to it and consider what solutions harmonize with its future. Thank you.
Thank you, Dr. Subaiya. Lovely photographs. You know what? Have a seat and then come back up for Q&A, if that's okay. Or sit wherever you want. But then come back up. The next speaker we would like to bring up to the stage is Azadeh Momenghalibaf. She is a philanthropist, an activist, and a senior program officer at the Open Society Foundations. And she will be speaking, I believe, about access, equity, and the public good.
Do I just press this? Okay. Oh, brilliant. Okay. Hi, everyone. It is such an honor to be with you to share my perspective on psychedelic medicine and public health. My name is Azadeh Momenghalibaf. I know it's a hard one. And this is my first Horizons conference, and somehow I serendipitously ended up on this stage, so I'm quite new. My professional background is not in psychedelics. Sorry, did this? How do I go back? Okay, no, nothing, never mind, sorry. My professional background is not in psychedelics, even if personally, like many, I've experienced the most profound healing and transformation through their use. My background is in global public health and access to medicines, and for the past decade and until quite recently, no longer there, so I worked at the Open Society Foundations, supporting advocacy to advance global equitable access to medicines as a human right. And to be honest, much of that work has actually involved challenging the current profit and monopoly-based pharmaceutical system that, let's face it, has a huge impact in determining who will have access and benefit from the medicines that we create as society. And like Kasha, I'm sorry, I don't know how this happened. Okay. And like Kasha, I'm also part of the HIV treatment access movement and harm reduction. So I'm going to draw from my experience working on access to medicines in other areas beyond psychedelics and share some of my deepest concerns, but also wildest hopes for this wave of the psychedelic renaissance. Okay, now it's right, sorry. First of all, wow, holy cow, it is such a dizzying and exciting time to be following the psychedelic space. It's hard to keep up with all the developments, the hype that psychedelics will revolutionize mental health, which is so compelling, to the hope that psychedelics might heal our world. But what gives me pause is when I see the headlines and financial reports that psychedelics will be a booming industry, valued at $69 billion by 2027. When I see the massive influx of venture capital investment, or the news about Compass Pathways securing its 5th patent on psilocybin. When I see all of this, I can't help but be concerned that the same forces that undermine public health around medicines and other areas could co-opt our collective intentions around healing, access, equity in the psychedelic medicine space. The pharmaceuticalization of psychedelics means that we are embedding psychedelics into an existing system, and that is the patent and monopoly-based, FDA-approved commercial pharmaceutical system. It is a system that might be designed to develop and approve pharmaceuticals for use in the medical market, but it is certainly not optimal for other outcomes we seek, like access, affordability, and equity. And you really don't have to look too far outside the psychedelic space to see the truth of this claim. We have new cancer treatments now hitting the market with million-dollar price tags. 1 in 4 diabetics in the US is rationing their insulin because of its price, a drug developed 100 years ago. 58 million Americans can't afford to fill their prescriptions, and the list goes on and on. There is an active debate around what medicalizing and patenting psychedelics will mean for ownership and access. And while this is not a new debate, this is not a debate that's unique to psychedelics, it is such an important one for this movement to be having, because it forces us to question how we aspire as a society to treat medicines. Are they commodities that can be monopolized for sale on the market, or public goods that should be available to all? To illustrate this point, and if it's okay, I really want to stay aspirational here, I want to take us way back. If this will work. There we go. Okay. This is Jonas Salk, the inventor of the polio vaccine in 1953. When asked if he would patent the vaccine and who owns it, he seems really shocked by the question. He famously says, "Well, the people, there is no patent. Could you patent the sun?" Fast forward to today, and let's take a look at the COVID-19 vaccine. While those of us in New York are wondering whether we'll get a 3rd shot, only 7% of people in Africa have received a single dose. From the beginning of the pandemic, those of us, I've been working on this for a while now, working on global vaccine access, we're calling for a people's vaccine. We thought, right, this is the moment when we would recognize our global interconnection and treat these vaccines as global public goods by doing things radically different. And that means having no patents or monopolies in the way of widespread access. As we speak, there is a fierce advocacy effort to push companies like Moderna and Pfizer, who hold the patents, to share their vaccine recipe with manufacturers around the world through what already exists, public interest mechanisms at the World Health Organization, like a technology and patent pool, and a waiver on all intellectual property at the World Trade Organization. Unfortunately, even during a global pandemic, this has not happened. What we have is business as usual, the prioritization of profits and patents over public health, as companies like Moderna and Pfizer are now slated to make 20 to 40 billion this year alone. And it's not just vaccines. I mean, just think about how much money there is to be made from the pandemic's toll on mental health. The global antidepressant market alone is expected to hit over 18 billion by 2027. I am concerned that the same profiteering and monopolization might happen in the case of psychedelic medicines if we are not hyper-intentional and vigilant to prevent that from happening. There we go. So let's examine the pharmaceutical patent system more closely. I know we've learned a lot about it already. In this country, we have a system that awards patents for a huge range of claims and minor modifications that give companies exclusive marketing rights which have been used to charge exorbitant prices. This is research from the top 12 best-selling drugs in the US from the organization IMAC. It's a group of public interest attorneys that we heard about as well. They found out that these pharmaceutical companies filed on average 125 patent applications on a given drug, many of which were granted, This allowed them to extend their monopoly for an average of 38 years. That means no generic competitors. And although many of these medicines changed very little in terms of therapeutic benefit, companies were able to increase their prices on average by 68% because of their extended monopoly period. Sadly, this is what our patent system has come to incentivize and reward: frivolous, excessive patenting that is more about strengthening and lengthening monopoly periods for profit seeking. I know the psychedelic patent space is still nascent, but there is a risk and already some concerns that psychedelic medicines could, again, if we're not careful, might go down a similar path. Ultimately, there's so much work to do to restore the integrity of our patent system. Okay. That's the end of my slides, but that slide's really distracting, so I'm just going to leave it blank. Look, I share all of this because we can have the intention of ensuring access and equity in psychedelic medicines, but let's be clear-eyed about the systems we're introducing these medicines into. I'm not naive, of course. I understand it takes significant investment to do research and development and to get a drug to market, and that patents are often part of that process. But too often, I have seen our financialized pharmaceutical system, focused on maximizing profits and shareholder value, undermine public health and access. And so my deepest fear was that the same forces might co-opt the psychedelic medicine space. But then I attended the Horizons Business Forum on Thursday, and my fear slowly transmuted into a wild hope that maybe in the case of psychedelic medicines, we might actually do things radically different. Even as we work within these systems, we can do so in a way that sets bold, transformative precedents that center and reclaim equity, access, and the public good in our medical system and beyond. And I'm inspired to see that already happening in this space. Honestly, as an outsider, it's incredible to see these transformative approaches like Usona's open source drug discovery model and MAP's Public Benefit Corporation. I mean, we've learned so much about those already, to North Star's guiding principles to keep the business sector and investors aligned to a powerful set of ethical values, and to Journey Collab, which is doing psychedelic drug development centered in inclusive reciprocity with indigenous communities. I mean, there are just so many examples that I've learned about in the last couple of days. I can't even list them here. But these are exactly the kind of transformative approaches like we should expect and support in this field. Psychedelics have helped many of us have an embodied experience of our interdependence and oneness with one another, this beautiful living planet, and the great mystery. And that also means doing the work to heal and transform the systems that drive extraction, inequity, injustice, and separation in our world. In 10 minutes, I have narrowed the definition of medicine into the pharma model. And I'm sorry for that, because of course, as psychedelics teach us, true medicine is so much more. There is no magic pill, no matter how affordable, for individual and collective healing. And so beyond access to psychedelics, let us be in active solidarity with other movements for health justice and systemic transformation, which is just as important. Efforts for a livable wage, adequate housing, and universal health care, to end the war on drugs, to secure racial and environmental justice, and to be in reciprocity and solidarity with indigenous communities to whom we owe so much, reclaiming and preserving their lands, sovereignty, medicines, and knowledge systems. And personally, I cannot wait to bring the access to medicines movement that I come from to join forces with those in the psychedelic space looking to possibly transform our pharmaceutical system for the public good. So can psychedelics create a better world? Well, clearly that seems up to us. We are co-creating the setting within which the psychedelic renaissance is taking place. And my deepest hope is that this movement, with the power of psychedelics and the intention for collective healing and transformation, might give us the much needed medicine that we need in these pivotal times. Thank you.
So I want to do a quick Q&A with Dr. Subaiya and Azadeh before we have all the speakers come up for a much larger Q&A. Saleena? Thank you both. Um, this is going to seem like a little bit uncouth, but we have a huge sort of lack of diversity problem in psychedelics. Remember Oscar's So White? It's like Psychedelics So White. It's up to us to figure out what the answer is. It's not up to you guys to figure out what the answer is, but I am still looking to you for your thoughts on how to sort of improve the diversity situation, both among providers and sort of partakers. Most of the people in the research protocols, the participants, are also not particularly diverse. And I guess the first step is admitting you have a problem, and then finding ways to pick it. But if either of you would like to sort of give us any of your thoughts, what's to be done, though I know it is in no way your responsibility to figure out what's to be done. Is this thing on? Yeah, this is portable, sorry.
Actually, we were discussing this issue over lunch today, and so what are the solutions? And I'm not pretending to have the answers, because I think we don't really have the answers for many medical problems we're facing. I think cancer treatment and diagnosis is a really great example. People who are from populations of color, people of color, are actually less likely to be diagnosed and treated than white individuals. So one of the things that we've seen that's really effective in reaching spaces like this is engaging with community leaders. It's a huge act of social mobilization that takes place. One example I can speak of is through vaccination campaigns. So they need to, vaccinate maybe like 95 to 100% of an entire country, which takes an immense amount of effort. And so what people will do is coordinate with nonprofit, government actors, private sectors, and they will reach out through community healthcare workers. These are actually individuals who live and work within communities, especially minority communities that are high school students or maybe first year in college. And they've built systems of trust within those communities. And then they can share, okay, first you recognize that you have a mental health issue. Is this something that you feel comfortable talking about? They may even know who has mental health issues within those communities, just by virtue of knowing everyone so well. So this is one way that we can go from kind of like a big picture view of engaging all these actors, and they do it. They do it every year in countries that have far less resources than we do, down to a community level. It's just one suggestion.
Yeah, I agree with all of that, absolutely. And the one thing that I will add, and something that I learned very much from the HIV movement, is the saying of nothing about us without us. And so it's really about reaching out to the communities, lifting up the leadership that already exists within those communities. And I was a philanthropist until like 2 weeks ago, sorry. So now I get to just be an activist, it's great. And having no strings attached with some of the funding and really allowing that leadership to sort of develop and thrive on its own.
Azadeh, you're reminding me that you just left Open Society, which means, are you looking for work? Are you taking a little time off first? Maybe in a few months, would you like a job? You want to let us know,
I'm
what
hoping we
what
have
your
more
specs
relevant
are.
questions.
I think it's relevant to you and me, that's enough. Do you have another job lined up, or are you?
No, I don't have another job lined up. Thank you.
It's like a Yenta thing. I can't help myself. Oh, you're single? Okay. I'm
looking for my calling, so
You're looking
if
for your
anyone has
calling?
advice, yeah.
Maybe someone here has a calling card they can give you. I guess the other thing I would want to bring up in talking about sort of access and equity is this idea of insurance. But I think, even if insurance covers it, there are so many people who don't have insurance or who don't have that kind of insurance. And I think the bottom line is that we need some sort of national health service so that we all have the same kind of insurance, and that is equity. I don't know what your thoughts are about that. Thank you.
I'm Canadian, so.
So tell us about, so anyway, I do want to hear what you both have to, the thing I always say about insurance is like, it's so boring, it's so dry and boring, but it's crucial, it's vital, it's an important piece of the conversation. It's the infrastructure that we are all missing, and it's like the elephant in the room, like it has to happen. But it's not going to fix everything.
Yeah, no, I mean, I agree. Like, I think that's really simple. I think we need everyone to have access to healthcare. But again, it's like I said in my talk, access is just one piece of the issue. Just building clinics everywhere doesn't necessarily mean you're going to improve outcomes. Again, this whole issue, I keep saying social mobilization, like what is the message we're trying to deliver is so critical, and going through alternative methods of delivering it. I mean, let's face it, we're kind of in an echo chamber right here, and I think it's really important that we step outside of that and try to understand why are, minority groups hesitant to engage, which is even discussion of mental illness, So, I mean, yes, step one, of course,
right.
Yes, provide healthcare to all, but
that comes back to this stigma issue, and, it sounds like the ER docs, really, that stigma was the thing that was stopping them from getting help. And these are doctors.
So it was stigma, but it also was not understanding that help would be, like speaking to someone would actually help them. So it was I don't want to be judged, I want to be strong, and then this isn't even going to help.
Right.
So it was kind of,
I do want to mention actually that there has been talk and sort of early stages of trying to put together a protocol, MDMA-assisted therapy for trauma that sort of first responders and medical providers have undergone with COVID. Casey Peleos and Willa Hall down at Nautilus Sanctuary are talking about having, I don't know how far along they are. I'm sure they need funding. I'm sure they need everything that everybody else needs. But it seems like a good idea. I'm sorry to hear about your long COVID. It sounds pretty damn terrible. So on behalf of viruses everywhere, I want to apologize for that. I don't know how to, I'm sorry that did you get sick from work?
Yeah, thank you. I think it's one of those things where we all get gifts in disguise, and so what can we learn from the hardships that happened to us? And I've learned a lot.
Yeah, well, I imagine you're going to have newfound empathy, not only for people sort of fighting chronic illness, but especially those people who don't get diagnosed, who aren't believed. There's so many things in the beginning where we don't know it exists. Like, I had somebody calling the ER when I was a resident and talking about how sick he was from stopping his Effexor. I'd never heard of antidepressant withdrawal. I never knew that it was a problem getting off of Effexor. I had no reason to, I believed him. but there are plenty of people who have symptoms where they're not believed, and it's one of the many traumas that people experience, especially women, engaging with the healthcare system, is that instead of the doctor saying, I don't know what's going on with you, or I'm not sure, they say, there's nothing wrong with you. I've experienced that. I'm sure a lot of women here have experienced that, and it's incredibly frustrating. So I have tremendous empathy for what you've gone through. And now we have some other questions. One question, and then we're probably going to amass a large group for more questions.
Saleena, this question is for you. In what way did ayahuasca help you manage your case of long COVID?
Good question.
Come find me after, and we can chat.
I was like, good question, and good answer. What else? Another question, perhaps?
Let's move on to the panel.
Okay.